Hello, namaskar, and welcome, like I always say, to the Knowledge Series where Asianet News and Amrita School of Business under Amrita Vishwa Vidyapeetham bring on board experts and really the who's who, as you've seen in the past editions as well, from the academia and the industry to share their perspectives about those matters and those topics, those themes that are pertinent, that are relevant to your career and growth because we care for you that way. I'm the moderator of the series. My name is Shikha Singh, and talking about the healthcare market and healthcare policies in India. Why are we going to discuss about this topic today? If you're just thinking, I'm sure it's a no-brainer, right? Because healthcare has become one of the largest sectors of the Indian economy, growing at a CAGR of more than 22% if we talk about in the year 2016. And I'm sure you're aware, with a potential to generate over 5 lakh new jobs every year. So it's that critical. You know how COVID-19 pandemic has not only presented challenges, I would say, but also because there's everything good and something that's also challenging, it has also presented several opportunities for India as a nation to grow. The crisis has actually opened floodgates, so as to say, for the Indian startups, many of whom have risen to the occasion and have also accelerated the development of low-cost, scalable, and the quick solutions, to put it that way. Well, furthermore, there is also an impetus that we see to the expansion of telemedicine, the home healthcare market in the country as well. The Indian government has taken deep structural and also the sustained reforms to strengthen the healthcare sector by also encouraging FDI, as we are aware. But besides everything else, all you young minds, I have to say, and like I always love to address you this way because young inquisitive minds, you know what's very, very fascinating to note is that Indian medical service consumers really become more conscious towards their healthcare upkeep, like all of us, you and me as well. So we need to rethink our traditional care models and create alternative settings for delivering high quality, safe, and also most importantly, personalized care, because that way delightful experiences are the ones that ultimately, when get rendered, create a difference. Only those who act early and, of course, agile enough, fast enough will be able to really turn those challenges, I would say, in the healthcare into that opportunity. It's going to be a very, very interesting session today. And let's get our first guest introduced to all of you, whom you would be shortly seeing on the screen right there. So I would want all of you, wherever you're sitting, let's just put our hands together and welcome on the screen Dr. Angensen Gupta, the Assistant Professor, Amrita School of Business, Bengaluru.
Hello, namaste everyone.
Namaste, Dr. Angan. I'm saying that on behalf of everybody. Very, very good evening to you.
Thanks a lot, Shikhaji. Nice meeting you here. Thank you.
Thank you. Dr. Angan, of course, we are all ears and we'll be, hearing your perspectives just in a bit. But, we love putting our special dear guests in a spot. So if you allow me, I'm going to ask you this one little question that will help us get to know more about you.
Yeah, sure.
All right, let's go ahead with that. So, okay, as everybody knows, this is Shikha's rapid fire round at our webinar series. And Dr. Angan, I'm going to ask you, just in case if you had a magic wand, which you could just wave, what is that one thing you would want to change in the healthcare industry?
Yeah, I will not one thing. Can I mention about two things?
Okay, we'll give you that liberty to do so.
Thank you. So the first thing is that under this scenario, we see that the Ukrainian students, those who are going to Ukraine to study medical and stating the reason that it is more affordable over there. So the first thing is that medical education should be affordable to everyone. So we talk about affordable, accessible medical care, health care services, but I think it should start with the education being affordable to all. That is number one. And the number two will be that I have seen the plight of rural people to avail proper medical care. So probably I would like to see healthcare professionals, educated healthcare professionals available to the poorest and the remotest of the places of not only in India, globally.
I think, Dr. Angan, yes, you were a little verbose with my rapid fire round, but I think the points that you mentioned are really thoughtful. So thank you so much for answering that so graciously. And we just hope, and of course, we'll be actionable enough to really, sort of make this really happen as you envision this. So thank you for joining us. We'll have you back on the screen just in a bit. But right now, please allow me to introduce and welcome our next and in fact, the final guest for the evening as well. This time, all of you have to clap for Dr. Naveen Thomas, who's the former CEO, Bangalore Baptist Hospital. Warm welcome to you, Dr. Thomas.
Good evening. Thank you, Shikha.
Very good evening. Dr. Thomas, I have to say this one thing to you. Of course, we've had our briefing rounds and we just met backstage a bit ago. I really admire how eloquently you sort of speak, and it's just so very well groomed. So there's, I think, a lot to learn from you as a person.
Oh, thank you. I must tell my wife that.
Please do so. I hope she's not around though.
I've sent her the link.
It'll be a good thing though. All right, thank you. And Dr. Thomas, before we let you go, okay, here's your question. I hope you're prepped to participate in a rapid fire round. Okay, tell us something very quickly about yourself that your bio doesn't have.
I'm good at acting busy. So that's a skill that one acquires.
Yeah.
And yes, especially as medical professionals, as doctors, they say apple a day keeps the doctor away, but yes, there is an addendum if you aim it correctly. So yes.
The choice of words and acting busy. I think that's a beautiful thing, but I'm sure with all that you've accomplished, you have been really, really busy, apart from the fun side of it. So thank you so much for joining us. We'll have you back in some time.
Thank you. It's my pleasure.
Thanks a lot. So I think that's how the vibe is looking like, everyone. I'm sure you're all geared up to sort of listen to them because, of course, the wealth of experience that they bring onto the table. Yes, post-union budget, India is set for the virtual healthcare 2.0. Yes or no, we will find it out actually from our experts also. But right now, here's just sending all of you a gentle reminder to please cast your questions via the comment box that you see on your screens. As you hear our experts talk, anything related to their talk, they'll be happy to take it up. We do have a dedicated Q&A interaction towards the end of the webinar, like always. So right now, it's the time that I talk in detail about our first guest. Yes, of course, Dr. Angensen Gupta, if we talk about him. And as you would see him on the screen right in a bit as well, he has earned his PhD from Maastricht University, the Netherlands, on health economics and policy. Dr. Angan, we would just request you to take up the front stage from the backstage so that, all right, good to have your site actually.
Thank you.
Right. Allow me to please further talk about you as well. So yes, I was just sharing with my audience members that you've also, you are a development economist and a demographer. Now that's interesting. You have 14 years of research and 8 years of teaching experience, if I'm not wrong, at the postgraduate and the PhD level. And Dr. Angan, you've been teaching health economics at Swayamprabha and NPTEL platforms as well. Of course, you've published in the top international journals. You've earned a coveted fellowship from TIFAC, the Ministry of Science and Technology, Government of India, to conduct research as a young summer scientist in IIASA, Austria. You're going to talk to us today about the healthcare market imperfection and delve straight into the health policies in India. And very interestingly, the populist argument is what you're going to focus on. Of course, Dr. Angan will ask you, what is it that you don't do? But for now, just over to you.
Okay. Thank you very much, for your nice, kind introduction and compliments. So I'm not sharing any presentation here. I'll just give you an example chat on the healthcare market, the health policies, and the imperfections existing in the healthcare market currently in India, and would like to look at this through the perspectives of the populist policies. And we have often heard of this word, that populist policies, but it is getting a lot of attention these days, especially in countries like Latin America countries. And populist policies, let me just introduce populist policy in very brief words, that it has both the rightist and leftist ideologies, and it generally means that the policies should focus on the mass demand, the mass need. And however, the problem lies when the focus of such policies is on the elite rightist wings, and that takes the policy framework towards an open market, heavily privatized scenario. It is often fine in certain sectors of lives and livelihoods, but when it comes to education, healthcare, that raises serious concerns. And we have been observing the debates around the growth versus development in developing countries. We have been hearing noises between Professor Amrita School and Jagdish Bhagwati about what comes first, growth or development. And this directly aligns with the dilemma of how we involve a populist policy. And let us first talk about why the policies need to be thinking of whom should focus, which the policies should focus. India is a large country, and it's a cash-strapped, rapidly developing country, but still the amount of spending that needs to come to healthcare has been really limited. In 1978, the Alma Ata Declaration by World Health Organization states that health for all by the year of 2000. Are we there? We are in 2020, 2 decades already passed by. The rights to health, especially for the underprivileged sector of population, has not really been ensured. There has been gross inequalities. We have taken the existence of such inequalities politically, socially, economically, geographically into cognizance, but nothing much has really happened to reach to the marginalized sector. And probably there are valid reasons for that. Every human being is rational. Why a doctor does not want to go to the remotest of the places is valid. At the same time, why the government cannot bring the best of the healthcare closest to every nook and corner of the country, we also know the reason for that. But however, who keeps on emphasizing on promoting universal health coverage that should look into health promotion, prevention, treatment, rehabilitation, palliative care, so on and so forth. It's on the particular country's prerogative that how they are wanting to take that over there. While we talk about this availability, accessibility, and the quality of healthcare, the global strategy on human resource by World Health Organization also states that the health workforce allocation has really been a serious concern in most of the developing countries, and hence the supply and demand, the gap is existing, and is existing more seriously in rural areas as compared to urban areas, and we all know that. On top of that, what has happened, as the government could not probably, fill the gaps, there was a lot of, vacancies in the market where the private market players filled in. And these private market players are either so-called quote-unquote profit-making healthcare providers, or we have seen some wonderful charitable hospitals, across India have been doing great works, So now, while we venture into the discussion on privatization, let us just quote that, or let us just state about some typical factors that contribute to these market imperfections. For an example, lack of awareness among the patients and the communities is a significant factor that leads to market imperfection, because when they are not aware about the services being given, about the healthcare need they have, the health seeking behavior remaining very poor, they are often not either being provided with, or they are not demanding the correct need to the correct persons, and often been manipulated. Shortage of supply of healthcare providers is another very important reason. We have seen insufficient information dissemination from medical professionals to the patients. It can be at any level, from the grassroots to the topmost. Heterogeneity in health as a commodity, and how we infer health as a commodity, the importance we attach with that, and upsurge in the profit-making private institutions and the government regulations working around the control, keep a control over the such market growth. We have seen that such involvement from the government has been limited, and the positive externalities that are coming out of the private organization often turns out to be negative externalities translated to the healthcare cost, either financially or physically, to the poor patients. The quality assessment has been ignored, and and often we have seen, just because of the supply demand gap, because of this market imperfection, the out-of-pocket expenditure has remained very high, because the health insurance penetration of health insurance is very limited. Health insurance was mostly driven by private health insurance, or other schemes were there, ESIS and all, did not penetrate to the people who really needed them. So, so that really did not help the scenario, overall scenario, healthcare scenario, to perform at the most optimal level. We have this after 1990s, even though we have seen that the privatization has grown and often tried to match the demand versus supply, but then, why it did not connect to the community, to the best healthcare facilities, because of healthcare referral. I will try to little bit, focus or emphasize on the healthcare referral. And this unorganized healthcare referral, today, one of my maternal uncles, he just asked me that, where are we in India? He lives in Canada. He studied there. He is very elderly now. He was a professor in one of the universities there, and he just wrote randomly, looking at my post in Facebook that I'll be delivering this lecture, that where are we today? Can we really connect to those who do not have information about where to go? We are 70 years down the line since our independence, and do they know where to go? So this directly connects to the question of healthcare referral, and even if there is a referral, the referral is often not strictly streamlined by the government, and then we know that there has been often irregularities about how a patient is being served. So there is no proper mechanism to govern the caregiver, the treatment being given to that patient. So naturally, the question is, arriving, that is privatization helping the Indian market? But we are discussing about public-private partnership. For an example, Janani Suraksha Yojana in Ayushman Bharat, there has been, a conspicuous recognition about the fact that we need the private system, public system, NGOs working hand to hand, the intersectoral approach, which has also been very prominently recognized in Sustainable Development Goals, that you need to have an intersectoral approach while attaining any of the Sustainable Development Goals. So these referrals play a really significant role while a patient is being transferred for certain cause from a practitioner to another practitioner, from an institution to another institution, where they have not much information about the medical condition, the medical legal issues that may encounter, or what is the level of services that should make them satisfied or not. So, so we have seen that such referral care is connected in not only in India, not only in developed countries, but also in India, from the primary sector to the tertiary sector. In public sector, we have this Ministry of Health regulated in the state government support system, central government support system, rural and urban, very specific, very clean, linear systems. We have Ministry of Defense, Ministry of Railways. In private also, we have these multidisciplinary hospitals, specialty hospitals, as well as we have private clinics around us. But probably there is a strong gap again between rural and urban, metro cities and smaller cities in one state to another state. And we have seen that the migration takes place from one state to another state. And often when a patient is coming from Kolkata to Bengaluru, they do not have much idea about to whom to go. Maybe they have come to know about a particular hospital, but they do not often have idea about which doctor, which specialty, so this additionally take resources away from them. So this, I seriously think that Ministry of Health and Family Welfare have started, looking at it, and they have been involving other empaneling in all this. It can be individual doctors under JSY, it can be involving them empaneling private hospitals, NGOs, charitable hospitals under Ayushman Bharat and other healthcare schemes, state level or eventually central level. In rural, yes, it has remained very simple and linear, but even though it has been underutilized, mostly because the frontline health workers, which is again now being attempted to strengthen that, but still the frontline health workers and the range of services they can provide, the education, healthcare education that they have, has remained limited. For an example, the midwives cannot take obstetric decisions while delivering a child, even if it's an emergency situation. The doctors are not there, and JSY suggests that you can avail a private practitioner's help. They will be given some money to avail the services. But then the midwives, unlike in many other European countries, are not supposed to take the decisions to help to deliver the baby, because they are not probably equipped enough with the knowledge. And we always have seen in many other places that the quacks and home remedies have a very strong presence in the health-seeking behavior among the rural residents. The data, when we talk about the digital health, the data, the way it is being connected, the forming the network using the data has remained poor. The resource mapping, planning, and monitoring even at the district level has remained shambolic, and even the schemes are being floated. The awareness generation, the proper monitoring and evaluation and follow-up has remained poor. So the rural India's healthcare system, even if there is a proper referral, has not really been performing satisfactorily, and there is a serious delay in treatment and the out-of-pocket expenditure increases, resulting in the vicious circle of poverty. In urban, India, it's private healthcare facilities are the institutions where the patients they rely mostly. Even if we have the government medical facilities, one of my PhD student is working on this referral, and so they do, the common people, even I do not have good idea about the public healthcare facilities around me. I know private healthcare facilities, I know the charitable hospitals, but I have no idea about the government facilities. Not much idea that I can rely on. I can go and seek treatment. No, I don't. There is serious information asymmetry. The lower is the information, or the higher is the asymmetry. The lower will be the trust. The lower will be the trust. The poorer will be the health-seeking behavior or health-seeking tendency from those institutions. And then there is this snob effect that, if I take treatment, or my friend has taken treatment in Colombia, Asia, it looks like a 5-star hospital or hotel, and I should rather go there. If I do not go there, I go to a simple 20-bed nursing home for even a simple thing that really does not justify my status. So the snob effect in many cities, we have been observing that the snob effect, or the bandwagon effect, that if my friend has gone there, I need to go there, or where I pay more, I get better facilities. This also leading to the privatization, and then the private health insurances, and there is adverse selection and moral hazard associated with that how I seek a treatment. And I can directly go to a specialist, ignoring the steps from the family physician and taking help of a regular mechanism. And while the patients, the community is not willing to be aware about the steps required, it is also very difficult to satisfy, to convince the patients, difficult for the doctors to convince the patients that you should follow this mechanism, and they do not have enough time as well in most of the cases. They are overburdened. So even if there are referrals that for the diagnostic center for one specialization to another specialty, we do not see that proper referral slips being given, and the patients are also not very aware while being shifted that why are they being shifted. So there is again the information asymmetry, but at a different level. They take help of several digital health platforms these days. Again, if we interact, we know that while they take, we get several kinds of these ratings, comments in Google and all, and they all can be manipulated. So we don't know how to trust and which to trust, and we take decisions based on these ambiguities, around these ambiguities. And urban poor, especially those who are coming from rural to urban, from another state to one state to another state, does not have their enough strong identity proof. They struggle to avail any scheme, and at the end of the day, probably they cannot go to the expensive private medical care. They go to medical shops and take medicines, or they just try to follow their traditional healthcare beliefs. So even if the National Urban Health Missions promoted urban primary health centers, one for every 50,000, not remained really very successful, because the promotion, the awareness generation was not really very, very strong. Yes, urban poor, they utilize that. That's because just a peer, but not probably the mechanism, not probably for because of the community health workers over there. So we have seen these. Before this 1978, we had this Vore Committee in 1946, which emphasized on the primary health center. More than 3 decades ahead of this Alma-Ata Declaration. And we had, after Alma-Ata Declaration, we had national health policies in 1983, 2002, 2017, understanding, assessing, and proposing policies based on whatever was needed. And they talked about, in 2002, they very prominently talked about engaging private health care providers and expansion of the overall public health expenditure, promoting the primary healthcare facilities and strengthening them. In 2017, they talked about quality improvement, which was not probably, it was probably more about the quantity, reaching out to people. Now in 2017, apart from these rights, apart from the universal health coverage, they're also talking about the quality of all different preventive, promotive, palliative, curative, so these different needs were not really very prominently known to the people, or was not really very strong. Yeah, in the 12th five-year plan, the NGOs had a strong place in healthcare scenario, especially for these NCDs, tuberculosis, blindness, and especially involving them in the rural care, connecting to the community as strongly as possible, because they have stronger foothold at the grassroots. So we have been observing that, well, there has been an attempt to connect the supply, demand, the market, the healthcare providers. But there have been fallacies, the gaps mainly related to the shortcomings in the public health facilities, its infrastructure, constraints in human resources, socioeconomic inequalities, environmental concerns, monitoring and evaluations, the regulations, referral framework, the communication facility, the network building using data, technology, so on and so forth. So what populism can do in health policies? Let me just wrap it up by stating that we need to utilize populism policies or populist policies positively. Its instruments should be very selectively chosen. The actions and actors need to be assessed empirically and regularly. The populism is fueled by social media, and the issue of post-truth, that social media sends a tremendous amount of misinformation as well. We have seen what could happen, what can happen during COVID era as well. So the media plays a very important role how we use the populist frameworks and determining the health-seeking behavior, health outcomes, and building opinions towards building a healthier society. And what populist policies can do, rather than building mistrust, it should be focused on gaining trust, building interconnections around institutions as strongly as possible, and the public, private, community, NGOs, everyone should be aligned. Information should flow. First thing is that affordable. The second thing is accessible, and the knowledge is most important part. And hence I see populism is ubiquitous in the Indian healthcare scenario. And we just need to frame proper policies, and not only framing it, we have seen that policies are being floated in last few decades. Populism is being floated, but there is lack of implementation. So the implementation must be really, really strong. So thank you. I stop here. I hand it over back to Shikhaji. Thank you very much.
Thank you very much, Dr. Angan, for your structured and, of course, very, very insightful thoughts. We'll have you sometime back on the screen for the Q&A round. But right now, I'm just quickly marching ahead, and I hope you've thought of your questions. If yes, do cast it right now. And as we heard about the populist argument there from Dr. Angan, I'm sure you know that the healthcare industry in India is projected to reach $372 billion by 2022. So we're close to that. Well, this looks promising. Let's further introduce and get our next guest talking. So Dr. Naveen Thomas would be right here on the screen, and greeting you back. And allow me to please talk about you, in terms of your qualifications, Dr. Thomas. You've completed your MBBS in CMC Vellore. Of course, there's so much that goes to your name, but I'm going to keep it short with the DND General Surgery qualification that you also have. Your MPhil from BITS Pilani in Hospital Health Systems Management. You are a general and pediatric surgeon at the Bangalore Baptist Hospital, and you've been a senior advisor to the hospital as well. So talking about at NABH, your role has been of a principal assessor, and you've also worked as an associate clinical lecturer in the Sydney Medical School and as fellow in pediatric transplantation. So there's a lot, as I said, that is to your name. And I'm particularly fascinated with what you're going to speak today. When I read about it, of course, the theme revolves around how you say that, one would have heard of hospitals for the haves and the haves not, and the have-nots, for the rich or the poor, the five-star or cattle class. But your submission today is going to be that it is possible to develop a both and model instead of just being stuck with an either and or paradigm. So we can't wait to hear your thoughts on this bit. Over to you.
Thank you, Shikha. I think we've just heard a very good talk about the interplay between health and economics from Dr. Angan. Just now, Dr. Sengupta. So it's been special. What I want to communicate today is about the different paradigms which are there, and wanted to propose that something is, there is a special paradigm which is very viable and doable and it's proven, and it's replicable in many places. So may I just resort to some PowerPoint as well. I will share my screen.
Please go ahead.
Yes,
the Power Talk being powered by a power presentation, like we say, and we can see that right on the screen.
Excellent.
Let's go ahead, Dr. Thomas.
Yes. So, Bangalore, it's 13 million population that we have right now. It's exactly 1 crore 31 lakhs and 93,000 was the last count, official count. And scenes like this are there in many places, the posh places, the real swanky places, and that's what we want our visitors to see, the foreigners to see, those who come here to see. What we don't want people to see is the underbelly of Bangalore. And this, many of you may not know, when I went to this place, I couldn't believe that such a place existed in Bangalore. It's almost, the 2.5 lakh people staying in DJ Halli village, the Dharavi, not really a village, it's a slum, and the Dharavi of Bangalore. And, so we have a choice, isn't it? Whenever a healthcare structure is being made out, you can either be aimed and, you can target something which is for the rich, or the, it is, you can ask anyone, the common man, this particular hospital, now, who can go there? Oh, this is for the rich. Oh, this is the general, for the general people, for the general crowd, the cattle class, or whatever it is. But can there be a different paradigm? There are many paradigms that we have seen in our country. CMC Vellore model is well known, of education, frontiers of science and being out there and attracting similar-minded people, and a large volume which makes it possible. Aravind Eye Hospital model, where it is a hybrid model and sustainable, and they have been able to replicate it. Now, it is the McDonaldization, as they use the term, the Walmart model, the NH, National, the Narayana Hridayalaya model, where It's the health city model, large scale of it, the economies of scale helping cutting down cost to a great extent. Yeah, so multiple models that we have seen. Those of you who are in the business, the MBA streams, you can look this up in Google. You will be directed to the Makunda model. It's a mission hospital in the south of Assam, border of Tripura. Very interesting. Wharton Healthcare Management, the Alumni Association, they conducted a study of, and it was published, accessible healthcare in low resource setting. Very interesting. They came up, they almost have 6,000 deliveries per year and a very large scale, but in a low resource setting, that it is doable. You can look that up, and a very interesting study. There are other faith-based models which attract people who come and say, okay, I will donate my time and efforts and talent here. CF Hospital in Tamil Nadu is one such example. Now, we have the either or model, either this or that. If it is together, no, it won't succeed. One group will not go to the other group, and it will not happen, is the popular understanding. But can we have a sustainable, a model which is both and, instead of either this or that, both this and that, and a cross-subsidy model, where because of the very nature of being a both and economic model, it becomes sustainable. And just wanted to present and submit the Bangalore Baptist Hospital experience. Now it's in the 50th year, 5 decades have passed, and 35% of the patients are from the private stream and 65% from the subsidized general stream, and that it is possible to extend. Now, be it oncology services, even, for example, bone marrow transplants during the COVID season, about 18 of them, and, big cardiac, interventional cardiology and cancer and mother and child services and advanced surgical intervention. Yes, the jazz and the glitz is there. That is necessary, but it is to provide the ambience to those who ask for it, pay for it, need it, high-tech care, intensive care, which is given a lot of importance, but at the same time, larger volume being the highest, the biggest number of, making the biggest number of babies in one sense for any private hospital, more than the private medical colleges in Bangalore. And, but what I'm excited about is that it is possible to reach out. Now, in the 12 slums of Bangalore and a large, Bangalore rural district where 1 million are covered, and in the slums, another 1 million are covered. That is what is not seen in the main hospital, but it is possible to do this, is something which has been demonstrated. Now, the community engagement, even through the COVID times, even delivering medicines, more than 100 people being actively involved in the outreach services into the slums and in the villages. And this has been something which is very, very gratifying. And we recognize that this is really possible. Now, being involved in the village committee owned or the slum committee owned initiatives where income generation is done. Right, this lady who got a push cart, and she is there earning livelihood, and the villagers or the local committees, they own it in one sense because their views are taken into account. It is not just thrust down their throats. And there is a cheer which is spread, and that is exciting. And when some of our people went and visited, they came back and said, oh, it makes my work here very meaningful. Suddenly I realized that I am part of a bigger mission, which is a bigger movement, not just work. And that is special. And being involved in child labor, slowly working with them to coming out of that, that is something which can be done. At the same time, providing the, cutting edge technology or whatever is required in the hospital, and making a difference in women and children really pays off. And, the happiness which is shown in their faces, it is something to be seen, to be believed. Now, mobile clinics, and over time, people trust you. Just try going with a mobile clinic somewhere. Nobody accesses, nobody believes you. It takes time. And once it takes time, it is very, very strong. And the disability program along with the government that we do, 60,000 people with special abilities or disabilities that we are responsible for. That has been another special area. This was one person who agreed to be photographed and used, who had Hansen's disease, leprosy, which is gone, but there are some people who still have it and who have the disability. Palliative care, and in a big way, home-based palliative care, rural and slum-based palliative care, along with urban units, and giving dignity in the life-limiting diseases. And suddenly, the person there feels respected. Many of those who come to the clinics, they say, what is special is that we feel respected here. And that makes it special because people demand respect. And that is something that it is possible to communicate, show in our dealings. And suddenly you have a group of people who say, yes, I'm excited to be part of this team. And it becomes a reality. Just wanted to show you now the gross patient income with growth. Yes, it increased drastically, dramatically. It's a large operation. But what I'm really excited about is look at the concession growth. Now, 25% is an aberration. That was because of the second wave of COVID and all that. But more realistic would be 18 to 20%. And that is doable. Now, this with only 5% coming as an external donation, mainly patient generated. So suddenly you have a model where you're saying this is sustainable. You can grow, develop, advance, and impact and sustain this. This is very gratifying. Now, we know that 35% are in cities right now. Over the 10 years, it grew from about 29% to 35% in cities. And we have 25% of those in cities. It ranges from 20 to 25, you'll know better, and in slums. And we are able to reach out. And all together, scaling new heights. I still remember, a philanthropist donated a village center, the structure and the land around, to Baptist Hospital, and the governor of Karnataka, this was almost 18 years ago, he had come to inaugurate this, and he made this statement. Large crowd had gathered together. He said, most of us here are Hindus. We are here to inaugurate a gift given by a Muslim gentleman. It was Professor Mumtaz Ali Khan who had given that to a Christian organization. And I remember the whole crowd applauding at that moment. That is special, working together, with people with a large footprint, making a difference. So, ladies and gentlemen, especially the youngsters, I want to tell you that this model is workable. It is not a sacrifice. You will enjoy it, and that you will attract new talent. Philanthropists will come and say, I want to give, but even without that, it is sustainable. It's not just dependent on that. And, staff retention, morale, just being part of something bigger. It gives you goodwill from all around, community goodwill, government goodwill. Well, it takes time. That is the flip side of it. Those who want exclusivity may not come to you, but then it has grown, beaten all expectations, and this has been wonderful. And we are grateful. So just presenting a model, both and model. I'm sure you will become ambassadors for this. Thank you very much. Back to you,
Thomas. Thank you. I think I was just glued to the screen that way. This was heartfelt in the way how you said, the feeling of being respected. So I think the best in modern medicine that way, as you say, can go hand in hand. And the vibrant, self-reliant model that you spoke of seems viable. And especially with the countries like us, it's very, very relevant at the same time. Thank you. I would like to, I think, rather than letting you go, I would like to retain you on the main stage and in fact, invite Dr. Angan as well, because very quickly we got some time in hand and we would be so happy to take up the questions that have just flown to us. Of course, virtually from the skies. Thank you to the audience for being participative. And Dr. Angan, welcome back on the screen. Let's head straight into asking you the first up that I'm going to take. Okay, can you tell us, both of you, what are the top 2 health policy issues according to you?
I will say, I will say that, the last one, that Ayushman Bharat, if implemented properly, could be a game changer. Because, it targets 50% of the poorest population, it connects primary, secondary, and tertiary sector. If surgery is required, hospitalization is required, cashless services to be given to them. Ayushman Bharat also includes the digital health platforms, the data sharing, and everything within the same platform for every single individual. So this, if implemented properly, this can be the game changer. The other one I will cite is Janani Suraksha Yojana, JSY. It has increased the institutional delivery, though it has, I think, side effect that C-section delivery is also increasing very fast, and but we are not yet sure. Not many studies have been really connecting these 2 issues together, showing a potential causality. But yes, Janani Suraksha Yojana has been successful enough in its target in increasing institutional deliveries and decreasing maternal and child health, child mortality. Yeah.
Okay. Fair enough. Dr. Thomas, anything that you'd want to quickly say on this one as well?
Yes, I think, I wish there are some tweaks which are made into these policies, which are rolled out already. For example, when it comes to Ayushman Bharat, private players, when they come in, allow co-pay and make it public, let it be transparent, and say, in this hospital, if you go, it is 100%, cashless. Here they are asking for 50% more, 25% more. There'll be competition. Open it out, and the consumer, in one sense, becomes the chooser, and unleash that power, rather than say, okay, this or nothing at all. And these institutions are recognized and these are not. So the consumer decides, unleash the private power into the whole system.
Got it. So that way the power remains with the consumer. I think fair thought by both of you. I'm going to take up this one, which I feel is very, very relevant for us. So they're talking about the brain drain issue, and that has come from Navika. So says that brain drain is a big issue for the medical industry in India, with destinations like Russia, Ukraine, etc., that are cheaper and easier to get into being popular choices among students, as we know. She's rightly saying. What solutions do you feel the government can come up to prevent this brain drain?
Yeah, can I answer that? Maybe
Please.
part of the answer.
Listen, I loved your previous answer too.
Yeah, just wanted to say that there are a lot of, there is some fluff which can be trimmed.
Okay.
Keep to the essentials. In fact, if you go to the Malaysian, even Chinese or the Ukrainian or the Russian system of medical education, they have been able to trim a lot of unnecessary things which will make it very, very expensive. So, so the real-time delivery of education becomes expensive. Ultimately, it gets passed on, and it breeds to corruption and unaffordability. So, they go elsewhere. So a lot of unnecessary things are there. Probably we don't have time to go into those details. Trim those things, keep to the essentials. We will become very lean and mean in one sense, but the gist will be there. We have the potential to become a great, great center of education.
That's very empowering to note. Dr. Angan, very quick thoughts on this one as well. How do we sort of prevent this?
See, the prices come down. I am not a healthcare professional by my training, so I do not know about the services or the education, the part of the teaching that can trim down the cost. But I also believe that the supply, if we could meet the demand, so that brings down the prices. That is the cost of medical education. So the moment there is supply, and Dr. Naveen very beautifully articulated the point of competition. So over here also it is eventually very, very relevant that competition in terms of getting optimal quantity of education, because there is a strong positive externality in sharing knowledge, number one. Number two, quality of education. So competition must not, what we have seen in mushrooming engineering institutes, MBA institutes, that the quality has often been sacrificed. In medical, we cannot let that happen, right? So the competition, the supply should increase, bringing in healthy competition, not compromising on quality.
So that would help us prevent that. Okay, noted. I hope that helps. And going to take up this one that has come. I know this is one question that even if you switch on the news channel, this has been discussed since the last 2 years and more. But of course, you'd want to hear your thoughts, experts. The healthcare system in India was stretched beyond limits during the pandemic, especially the first two waves, yes, we talk about. Do you feel such situations can be avoided or dealt with better in the future through healthcare policy changes by the government? Of course, God forbid that we have something, but if yes, how do we deal it better?
Yeah, it's
okay. Dr. Thomas, you can let's officially say that you can. We can have you answering this first.
It's a it is a matter of when rather than something or other is with the globalization, with travel, with everything else. We know that these are bound to happen. And when it happens, not if it happens, when it happens, we cannot stay on with the GDP allocation that we've had into health all this while. So it is a wake-up call. We simply cannot afford to do that.
It's not practical. Yeah.
Not practical. So it will not be able to, the system will not be able to deliver. Now, we having learned this lesson, I think there is already some positive moves. I hope it'll be a trend rather than one-off thing. And if it stays that way, there is hope for us, because it has to go to a minimum of 5%. If we don't do that, I think we are in for trouble.
Okay. Fine, Dr. Thomas. Dr. Angan has a smile on his face, but he wants to say something, I'm guessing.
Yeah, so I think that, no one had much idea about what is going to happen. The people had different kinds of thoughts and beliefs that we have enough
Yes.
immunity. We have seen these pandemics earlier. The Chinese people, they eat everything. We do not eat all these kinds of food. So they have different kinds of notions, or denominations. So, and eventually the government or the policymakers did not have much idea about the pandemic and what shape it is going to take. And they listened to the medical fraternity first, all the biostatisticians. Even I tried to do a projection, everything failed,
Yeah.
So and eventually they did not probably listen to the voices of the social scientists, the economists. And it's not only that the COVID pandemic has shown us the huge gap that is existing in the health services, the health systems in India, but also that how fragile our economy can be if we do not have a proper policy in place. For an example, we had several migration policies. No one had any idea about how that work and what they do and what kind of safety nets do that provide to the migrants. And eventually we met with such a crisis around these poor migrant people. And so it's not only about the healthcare crisis. It is also about an economic crisis, that are we resilient enough to face that crisis?
True.
Are we myopic, or we can see the distant future as well?
Yeah. All right. Interesting thoughts there. And there are two questions. Guess I'll just be able to take up this final one, it looks like, which is in fact a very beautiful question. And whenever we talk about healthcare, we tend to mostly talk about the physical aspect, but this question from our audience seems relevant because it says that mental health has ballooned as a matter of grave concern in the society due to multiple factors, and the pandemic has only helped to quicken the pace of this malice. In an encouraging move, the union budget recently has taken into account by announcing the launch of 23 new mental health centers, as we've heard of lately. Does this really practically solve the problem? How effective will they be? So if we can hear both of your thoughts.
Excellent question, because, one of the studies had shown that at some point in life, almost 43%, I found it difficult to believe that, have gone through some amount of, anxiety disorders or depressive illnesses, and 6% of the population having gone through major severe depression. And major severe depression has the risk of suicides and many other things. So you have a huge issue of mental health. Now, the budgetary allocations, giving importance to it, is a very welcome thing. But there needs to be a very good concerted effort of removing the stigma associated with this. I remember having my colleague coming to me and saying, I'll be late for work. This was not here. It was when I was in Sydney. The colleague came and said, I'm going to my shrink today. And I wouldn't have that, that language spoken here. Slowly it is coming down, but we need to really work on this. Saying there is no stigma attached to saying this, I need help. There'll be periods where I need help of, it is not, with a loose nut or anything like that it is much more. It is part of what we are, and we accept it. We have the maturity to accept it, ask for help, receive help, and move on as productive people in society. Otherwise, we have the capacity to drag down families and communities.
It's so true. And I think self-care is the best healthcare, they also say. So with the gap that's still there, it needs to definitely go away. It's good to hear on the budget front, but Dr. Angan, any practical steps or suggestions from your side as well? I know you represent the academia, but Anything
Yeah,
that you feel?
yeah. Say for an example, this in the national mental health policy that was framed in 2014, they
Okay.
addressed these issues of stigma, the suicide, the right-based approach, the budget allocation, the interdisciplinarity, the providing support to the families and the vulnerable population.
Yeah.
But there has been efforts, but in bits and parts. The collective effort, I do not see much collective effort from the government side has been taken.
Okay.
But yes, this again, for an example, this teleconsultation may help, but how many of us know about this teleconsultation?
That's so true.
Right? During COVID, maybe there was heavy tension between the family members, between the elderlies and the younger generations, between the husband and wife, and there can be it can be seriously depressing, and it can lead to serious mental health concerns. But if you ask them, they may be highly educated families. Oh, both of them are working from home, husband and wife, they are bound to fight. What is there?
Yeah.
That may lead to a serious family discordance, and
which has happened as well.
Yeah, so for an example, when we teach the students, I have seen a couple has dropped out. A couple of students have dropped out from this course because both of the parents were working and they were alone at home, stuck. One student, both the parents were working in bank, and he said that I could not take this loneliness, staying at home, taking the classes. And he joined 2020, and he's dropped out in 2 months. And I personally tried counseling him. I know other faculties tried counseling him. It did not help much. Right. And he said, I'm seriously suffering. And, now if he probably wants to go to a counselor, the society may say that all other students are doing it, how he cannot do it. Maybe he has some other issues. And that is apprehensive. So, it is probably a lot of awareness generation is needed. And that is the only way. If you ask that depression, many say that depression is a rich man's disease. Right? And we have nothing. We just drink alcohol and sleep off. It's a verbatim I have read somewhere. Just drink alcohol and sleep off. A very poor person. And that's the way they address their mental health. That has a serious implication on their physical health. Are we really teaching them about such balance of mental and physical health? So these gaps, it takes time, but probably certainly these efforts and connecting them with the system will help in future.
Yeah,
that's very realistic what he said. Yes, Dr. Thomas.
Just wanted to add on, if I may, insanity is hereditary, you get it from your children. No, I just wanted to say, it is interdependent. We need each other in the family, in the community, as journalists, as news folk and anchors and leaders of society, academia, the medical people, the student community. We have to say this is our priority.
I love it how the strings of the conversation are sort of winding up, but on such a beautiful note, and both of you shared how we need to just break this barrier as the stakeholders. We need to come from the shackles of it, break this, evolve in terms of our mindset, and of course the efforts that are needed from the government side as well, apart from that allocation of the budget. So that's a welcome move. But here's just inviting both of you to say your final words and just a sign-off note to all of our audience members, the one who would be the nation builders. Just your final note to them, after which we will wind up. It's been great and empowering to hear both of you, but just any final thoughts and your wishes maybe to them. We'll start with Dr. Angan this time. All right.
Okay, thank you very much. So I'll just say, I do not know who are you listening to us, and if I assume that you are the younger generation, I will just say that keep life simple. Take care of your health, both physical and mental, and address your health properly. And apart from that, just stay happy and healthy.
Loved it how you said, Dr. Thomas.
Yeah, my advice to all the youngsters will be keep away from us. But then that's on a lighter way.
Yes.
But then, just to say that these are exciting times where information is available and we share and work on it. Much can be done. And we really depend on the youngsters of today, to take this forward. And there is so much of excitement, enthusiasm, and wanting to do that gives us hope. I think there is hope because of you.
Said it so beautifully. And Dr. Thomas, if I could record everything that you say, your statements are like adages. So love chatting with you. Dr. Angan, thank you very, very much. Thank you to both of you for sparing the time and speaking with the young minds. Thank you. Wish you a lovely day ahead.
Thank you.
Thank you.
Thank
you,
Shikha. Thank you, Dr. Naveen. It was wonderful listening to you. Thank you very much.
Thank you to both of you. And I wish we host you and meet in person sooner than soon as well. Thanks a lot. Thank you very much. And of course, with that, ladies and gentlemen, the young minds, the year that has gone by, we know that has been an year of many questions, and healthcare 2030 will either be a developing India or a developed India, so as to say, depending upon what measures, both in terms of all aspects of our healthcare, are undertaken to fix the healthcare system. And of course, we are evolving and we are in this together. What an excellent vibe with our speakers and our experts for the day. And let's work together in building a healthier India. And with that, here's now inviting your colleagues along with you to join us for the next webinar that will be centered in and around for the BTech and engineering folks this time, and for the ones coming up. So please stay tuned for the webinar details as well. We'll keep you posted on that. Keep following us and stay abreast with all the happenings that we're going to announce as well. From Asianet News and Amrita School of Business, I would like to heartily thank you for joining us, and more than anything else, for being participative at the same time. Best wishes from us, and take care. Keep smiling, be happy, just as our experts said. Thank you so much.